This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, this is Dan Ackerman from St. Luke's University Health Network, and welcome to the Neurology podcast. Today, I have the absolute pleasure of interviewing Jim Siegler. Now, Jim is a stroke and vascular neurologist and medical director of the Comprehensive Stroke Center at the University of Chicago. He is very well known and well published in the world of stroke. And today we're going to be talking about his paper titled Outcome of Patients with Embolic Stroke of Undetermined Source Treated with Antiplatelet Agents or Anticoagulation, a multi-center cohort study. Jim, welcome to the podcast, and thank you so much for taking the time to talk to us today.
Thanks so much for having me, Dan.
This is such a hot topic. It's so important for every practicing neurologist, whether we're talking about in the hospital, in the clinic, trainees, people who've been doing this for a long time. So what was the impetus for doing this great study, and how did you get it organized, and why?
For many vascular neurologists, the question of how do we treat patients who have an unknown source of stroke, it's an unanswered question, and we know that these patients are at a high risk of recurrent stroke. Many of us have felt comfortable or complacent with this heterogeneous construct of an undetermined source of stroke, or ESUS, embolic stroke of undetermined source. And that accounts for 20 to 30% of patients who have ischemic stroke. But many of these patients still go on to have a high risk of recurrence, much higher than we see in patients who have paroxysmal atrial fibrillation, which may be 1 to 3% per year, but maybe not as high as the risk for patients who have intracranial atherosclerosis, maybe 8 to 12% per year. This patient population is very heterogeneous, and to consolidate them under the same construct, I think this serves in two different ways. While it's been helpful for designing really well-done clinical trials for testing anticoagulation against antiplatelet therapy, what we have found is that patients in these clinical trials don't universally benefit from anticoagulation. Some patient groups certainly do in these trials, but many of them don't. And to end the discussion at you have ESUS and we're just going to treat you with aspirin, I'm afraid leaves all these unanswered questions to the patients about their prognosis and the uncertainty that lies ahead. And also, we do tend to wash our hands of the situation. We give up on the workup of these patients, not pursuing these more occult mechanisms related to stroke risk, like maybe there's an underlying PFO that could be missed. Maybe there's some valvular abnormality or strands like Lambo's excrescence. Maybe there's a carotid web that's hiding there in the blood vessel wall that we didn't quite see on the CT angiogram. And I think that pursuing those unique mechanisms of stroke really can lead to more targeted interventions in an era of personalized medicine.
That was extremely well put. I'd like to get a transcript of that and just put it right where all of our new residents can see it, because I think that really hits the nail on the head of why this is so challenging. And as our diagnostic capabilities have continued to expand, and as the number of stroke patients continues to go up, you really do fall into this trap of, well, how much do we do? And when are we comfortable? And how do we treat people during that time of uncertainty? And it really has been evolving as a concept over the course of the last 5 to 10 years. Tell us, first of all, bottom line, because we want people to know what you found. So bottom line, what did you find in your study? But then if you could also just elaborate a little bit on the population that you looked at and how you organized the study, so we understand how to generalize this to the people that we're seeing in our clinics.
This was a retrospective observational cohort study of consecutive adult patients across 27 sites in the U.S. So the results may not be generalizable to all patient populations. The majority, if not all of these sites, were comprehensive stroke centers that do identify and treat patients with ESUS. And the treatment was at the discretion of the clinician. So the patients were not necessarily all treated with aspirin, which would be conventional best medical therapy, but some patients were treated with anticoagulation. And we didn't intentionally capture why they were treated with anticoagulation, if it was for the prevention of recurrent stroke, or maybe if it was for concomitant venous thromboembolism or some other thrombotic event. We really wanted to explore how in real-world clinical practice, treatment with anticoagulation could modify the risk of recurrent stroke in an ESUS patient population. Now, as this study was being conducted between 2015 and 2024, the concept of ESUS did change. In 2017, Bob Hart and colleagues updated the ESUS construct and added intracranial atherosclerosis, and more specifically identified left ventricular dysfunction and ejection fraction of 30%. They identified those other subgroups as inclusive or exclusive in the ESUS cohort. effort. But because we wanted a more comprehensive understanding and because we were exploring patients who were evaluated before this adjustment and knowing that many patients may not have been treated under that ESUS 2017 construct, we wanted to see how the outcomes played out with anticoagulation versus antiplatelet therapy. So in these 27 sites, almost 2,700 patients worth of data were captured over the course of 2 years of data collection. We looked at the primary outcome for this study, which was recurrent stroke as well as major bleeding events, including intracranial hemorrhage and death, according to the treatment that was recommended by the primary team. And again, it was treatment with anticoagulation versus antiplatelet therapy initiated within 7 days of the stroke diagnosis, presumably at about day 7. That's when treatment will be continued thereafter. Due to limitations of an observational study, we obviously didn't capture when patients switched over and those kinds of things. We did exclude and censor patients after they had paroxysmal atrial fibrillation. If antithrombotics were changed, we did exclude and censor patients who had a PFO that underwent PFO closure. So those elements were censored in our follow-up analysis, but we still evaluated the risk of recurrence over time. And what we found, the bottom line, is that there was no benefit in treatment with anticoagulation versus antiplatelet therapy in this real-world patient population of ESUS. And this lack of association persisted in 2 separate sensitivity analyses using propensity score matching. So we used inverse probability of treatment weighting and a 10-to-1 matched propensity score regression, owing to the fact that the majority of patients, 90% of real-world ESUS patient populations, are treated with aspirin alone, and about 10% were treated with anticoagulation. So a minority with anticoagulation, but still there was no apparent benefit with that treatment.
Little bit to unpack there, which is great. So in the final analysis, it was just over 2,300 patients that were included with central adjudication of patients that needed to be excluded because of a known cause for their stroke or a treatment that would have specifically dictated their management. And based on this observation, there was no benefit in the ESUS population of anticoagulation as opposed to using antiplatelet therapy with aspirin.
That's correct.
Now, part of how the whole concept of ESUS came about is this idea that patients who have embolic appearing strokes, we suspect the strokes are from sources that often produce emboli, and that the physiology associated with those sources is more amenable to stroke prevention with medicines that block clotting proteins like the direct oral anticoagulants. But it seems that structure really hasn't played out.
We know from observational data when we started to classify patients as having undetermined causes of stroke 20, 30 years ago that a large number of these people did have irregular heart rhythms, atrial premature contractions, and atrial fibrillation. And with more sophisticated monitoring strategies, we're finding that 30% or more of these patients are later having atrial fibrillation. So that makes intuitive sense that they would benefit from anticoagulation. We know patients with AFib benefit from anticoagulation with apixaban over aspirin, for example. But to further support that notion, we've looked under the microscope at these thrombi that are retrieved from intracranial occlusions for patients who undergo thrombectomy. And the thrombi histopathologically very closely resemble the patients who have thrombi related to atrial fibrillation. So ESUS thrombi look very similar to AFib associated thrombi, but it's not a perfect overlap. And so it stands to reason that anticoagulation would benefit these patients. And yet in now 4 randomized clinical trials, we've not shown that these patients are going to do better with anticoagulation over antiplatelet. And in fact, the stroke risk is greater in these patients versus the stroke risk of patients who are on anticoagulation for mechanisms like known AFib.
It's so interesting to have to do an about face like this. I remember it was really not all that long ago that we were trainees and we would see patients that have an embolic appearing stroke and say, well, we're going to put you on a medicine to block clots coming from the heart because that really looks like where this is coming from based on the MRI appearance. And I remember that whole script in my head. I don't even know how many times I went through it, but it turns out maybe that was not the best strategy.
Yeah, it's really hard to reconcile this and to talk to a patient about this when they come into the hospital and you tell them it looks like a clot went up to the brain and we're going to give you an aspirin or a baby aspirin. There's this kind of negative perception in the world about aspirin not being effective. It's a very effective medication, but really we're ignoring these other potential contributors to stroke by just relying on the antithrombotic agent of choice. When we see these patients come in, we think, okay, this patient was on an aspirin when they presented. Let's escalate treatment and start them on an anticoagulation. We don't see that that's helpful in patients who were randomized in the ESUS trials. We didn't see that was helpful in this observational cohort study of the CASPR registry. So it doesn't necessarily mean we should be doing that. We think that there are certain high-risk cardioembolic states because they are associated with a higher risk of recurrent stroke, like left atrial enlargement, left ventricular dysfunction, dysfunction, valvular disease. But not all of these subgroups have shown to be responsive to anticoagulation over antiplatelet therapy. So to say that we should just be doing that because our gut feeling tells us to do that, I think puts some patients at risk of harm because these direct oral anticoagulants are associated with a slightly increased risk of major bleeding.
Makes sense to me. I really appreciate you bringing up some of these patient level factors and looking at a study like this that's really very real world and very much right at the bedside in the hospital, in the clinic, to show that the results that we saw with these major randomized clinical trials really do translate into what we're doing with patients every day is so important. Looking at those patient level factors, let me ask you, what was the definition of ESUS, embolic stroke of undetermined source, that you used in this study? And just in your opinion, is there a way that you think we should be adjusting that definition now based on the 2017 update and what after this study?
So we used a very inclusive definition of ESUS, perhaps too inclusive, knowing what we know in 2025. But again, the study collected data from patients back in 2015. So our definition of ESUS was an embolic stroke that appeared embolic based on infarct topography on head CT or MRI. So it had to be a cortical infarct. It had to be a subcortical infarct of 1.5 centimeters or greater on head CT or 2 centimeters on DWI, or multifocal patterns of infarct. In the absence of an established mechanism, according to the 2017 criteria that Dr. Hart and colleagues put forth, we did allow for a little bit of wiggle room with those criteria. So we allowed patients to have an ejection fraction of 20% or more. And that was owing to the 2014 definition. I don't want to get into the semantics of that, but we felt that patients with an ejection fraction of 20% or more would be treated appropriately with heart failure medications, disease modifying therapies that could improve ventricular function, and that the ejection fraction could come up. There's also variability in measuring that ventricular function. We did include patients who had severe left atrial enlargement, patients who had cancer. We're still included in the ESUS population of CASPR, as well as in the randomized clinical trials. And while each of these may constitute their own unique potential embolic source, like webs and non-stenotic plaque, like we've mentioned, these patients still qualify as ESUS because they were randomized in these clinical trials. Many of them, the majority, were included in that 2014 and 2017 construct. So this does represent this real-world patient population that's quite similar to what we have seen from Arcadia and Navigate, Respect, and so forth, Atticus, and we do compare our patient population to those other trials just for an apples to oranges comparison.
So do you think that our current definition of ESUS is still reasonably functional, or are there ways that we really should be adjusting this based on all these trials that have come out recently?
I think there's been a lot of great literature on the topic of whether we should retire the construct of ESUS. And I don't know that we necessarily have to retire it. I think it's still a useful tool in our tool belt. But I think that to say that these patients have ESUS and that's it, and we're going to just treat with aspirin, I feel like that does them a disservice. I think that we have to start thinking about other contributors to embolic strokes that may be sclerotic factors in origin. Maybe there's an elevated lipoprotein A that promotes more accelerated plaque formation. Maybe they have an occult thrombophilia that requires more diagnostic testing. It's really reasonable in most patients to look for paroxysmal atrial fibrillation. We now know that these patients, even if they have several minutes to hours AFib and they're a high-risk patient population from the Artesia and NOAA-AFNET studies, that these patients will benefit over the long run with anticoagulation over aspirin. But that's not to say that we should settle and explore AFib as the sole contributor to, with a 2-year implantable loop recorder, to find that 6 minutes of AFib. You should be thinking about these other potential sources of embolism. I do see in my own practice a large number of patients who have an occult carotid web or who have basal and inferior septal wall motion changes with a normal ejection fraction. And we've seen patients with left ventricular thrombi in the absence of significant depressed EF, but to just treat the left ventricular thrombus until it resolves and say, okay, your risk of recurrent stroke is now very low. I don't know that we have enough data to say that with certainty. So to explore these different potential embolic sources really was the purpose of the CASPR study outside of a clinical trial where we are more rigorously randomizing patients to treatment.
At this point, just to dig into the details a little bit more, your paper mentions a recurrent stroke rate of about 4 to 5% per patient, a recurring stroke rate of 45% per year for patients with embolic stroke of undetermined source, which again is 20 to 30% of our overall stroke population. How does this compare, do you think, with what you expected? Is this in line with it? How does it seem to compare to people with a stroke of a determined source? Because we're trying to move people from this idea of ESUS into, hey, now we have done the investigations, we've defined why we think your stroke happened. How do those numbers play out?
The finding that these patients it was about a 6 to 6.2% risk per year of recurrent stroke, whether they were on anticoagulation versus antiplatelet therapy. I think that speaks, one, to the high quality data that's collected by the site investigator. So I want to give them kudos again for that. But also the fact that these patients were not prospectively monitored in a rigorous clinical trial where the annualized risk was 4 to 5%. We are seeing a higher rate in this real world patient population despite those parameters of a clinical trial. So I think that even with all the constraints of a clinical trial and the close follow-up and the really excellent care that happens in that situation, in real world comprehensive stroke centers, that risk is a little bit higher. And it's higher not because we're not treating these patients with the right antithrombotic, it's higher because of other potential sources of embolism that we're not quite identifying or maybe targeting. So as far as what does this mean, I think that the goal of this study really was not to just look at the overall ESUS patient population as we did here and ask the question, is one treatment with antithrombotics better than another, but was really to parse out which of these states or which types of stroke patterns or which types of stroke risk factors were really the ones that could preferentially respond to anticoagulation, for example, or if certain risk factors would be more specifically modifiable and how patients respond to that. Understanding those individual patient differences will really pave the way for future randomized trials, so that it was not so that we could get rid of or remove this definition, but really we wanted to understand which patient groups might we explore in a future randomized clinical trial to target with individualized treatment and know that these patients are not being ignored because they have ESUS or forgotten. We really are identifying these other mechanisms and treating them appropriately.
That's a great dovetail into what I wanted to ask you about next. You've mentioned a couple of times now the importance of not sort of settling for ESUS, not shying away from it as a concept, but at the same time being willing to say that, hey, we've got to do a reasonably extensive workup for a patient who has a stroke where the mechanism, the underlying pathophysiology is just not really apparent. So would you mind sharing with us a little bit, sort of what's your algorithm? You see a patient in the hospital or in clinic who has an embolic appearing stroke. They don't have your typical vascular risk factors. They don't have a ton of white matter disease or hypertension, hyperlipidemia. And they say, I'm so healthy, I don't understand why I had a stroke. So where are you going to start in your workup? And what do you think really needs to be included for everybody, as opposed to perhaps what needs to be included in some really specific patient populations?
In my own practice, we really abide by a lot of evidence-based practices in identifying which patients warrant which types of workup. If they're over the age of 40, especially if they have evidence of left atrial enlargement on any kind of diagnostic testing, these patients generally should undergo some form of cardiac telemetry to look for atrial fibrillation. I think that 2 weeks to 4 weeks is sufficient and probably cost effective, but longer monitoring could be helpful. I think that for older patients, screening for occult malignancies, especially if there's signs suggestive of cancer in the blood work with an elevated D dimer or with multi-territorial lesions, the three pattern sign that we see on MRI scan with infarcts in multiple territories. I do find in my own practice that not just proceeding with a transthoracic echo, but going for a transesophageal echo, as others have shown, can increase the diagnostic yield of finding a cardiac source of embolism, whether it's Lambel's excrescence or a severe mitral annular calcification, or if there's smoke in the left ventricle or left atrial appendage thrombus. Those findings may not be as easily captured with a transthoracic view. And I also see that a lot of patients do have these occult cervical pathologies in the arterial wall, whether it's a small web or non-stenotic plaque. So I'll look more carefully at that. And oftentimes we will see there is more plaque in the territory or in the artery supplying the territory of infarction, especially if it's a unilateral unifocal lesion. You'll see more intraplaque hemorrhage and lipid-rich necrotic core if you really window that CT angiogram down or look with a carotid ultrasound. We've got a couple of studies looking at that. So again, the most important thing is not settling after you've done the transthoracic echo, you checked an LDL and you've looked at the carotid ultrasound, but really looking for these smaller changes that may make you think, well, let's think about closing this PFO if they're Pascal probable. Let's think about potentially keeping them on a more aggressive lipid-lowering therapy for ulcerated or non-stenotic plaque.
Doesn't sound like there's a one-size-fits-all pattern or a paradigm that we can adopt here. It really does have to be based on the patient, their risk factors, their family history. Their testing as it comes in really has to inform the decision of what else you're going to be doing, and you take it one day at a time from there.
Exactly. Yeah. No one size fits all applies to ESUS here. And, as we also explored in this study, we looked at some of these subgroups and we're going to explore them in greater detail in later analyses. But in some subgroups where you might think that anticoagulation is better than antiplatelet therapy, because again, that was really the purpose of this main paper to look at antithrombotic strategies, we see that anticoagulation was not beneficial for the overall cohort, but it didn't seem to be beneficial in the cancer patient population. And that also was validated in Navigate ESUS and in the Arcadia subgroup analysis. We found that patients who have an intracranial occlusion, these patients whose thrombi histopathologically look similar to atrial fibrillation, we find that these patients don't benefit from anticoagulation. We do see that in patients who have left ventricular injury, so whether it's a depressed ejection fraction or wall motion changes of the left ventricular septum or the wall, we do see that there seems to be a trend to benefit for anticoagulation, and we're exploring that in greater detail. So some patient groups do respond differently to anticoagulation, but again, it's all about personalizing your treatment, identifying certain high-risk states and certain states that are more responsive to anticoagulation and antiplatelet therapy.
Let me ask you, in this cohort of, again, about just over 2,300 patients, about 230 were treated with anticoagulation, so just under 10% of patients with ESUS. Now, again, back in the day, I remember doing this with kind of most everybody who had ESUS. And so it seems like perhaps with the randomized trials that have come out and more recent guidelines that we're at least moving in the right direction with regard to applying appropriate evidence-based guidelines and treating with antiplatelet agents when appropriate, but also being willing to engage in anticoagulation when necessary. What's your sense of that based on this cohort?
Yeah, that remains a major limitation, unfortunately, the study, that we didn't capture the investigators' reason for using anticoagulant. They may have used an anticoagulant because they interpreted the PFO closure studies differently than others might have, where anticoagulation from a more recent meta-analysis may reduce the risk of embolism in PFO-associated ESUS. Or they may have interpreted WARSIF and other left ventricular function studies, the Commander heart failure subgroup analysis, and COMPASS and the Navigate ESUS analysis by Alex Merkler and colleagues, that where they see that anticoagulation may be of benefit. I know in my own practice, that's been my practice, is to anticoagulate patients with significant left ventricular dysfunction. But the heterogeneity in practice is something we didn't quite capture. We see that now, which is great. And I don't think that anticoagulation is wrong in these patients, so I don't want to be misunderstood there. I think that for some patients, anticoagulation is reasonable, and we know that the outcomes are similar. There's no better outcomes in these randomized clinical trials, but randomized clinical trials can only go so far to improve our understanding.
That's absolutely true. So at this point, I think we've touched on a lot of different topics associated with ESUS. I think we've been able to give a lot of great pearls in terms of how to approach these cases, how to start to work up these patients. And of course, there's so much more to learn both from this paper and looking online. But kind of bottom line, Jim, what do you hope our listeners get out of hearing our discussion today and hopefully going back and reading the full paper?
I think the take-home messages are that anticoagulation, generally speaking, is not associated with a lower risk of recurrent stroke, or at least a composite of stroke, major bleeding, and death. But for some patient groups, the risk of these outcomes, especially ischemic stroke, is different. And some of these patient groups may show some signs of benefit with anticoagulation. So while these other analyses would be considered secondary or they'd be considered post-hoc analyses, I feel like this information is useful. I feel like the quality of the evidence may not be as high as the primary analysis or the purpose of some of these trials, but they do inform decision making. And I find that when you start to consolidate some of this, it does increase the evidence to support changing practice, even if it does not constitute a high level of evidence according to our criteria. And I think that in any clinical trial or in any patient population where a treatment is being tested, I don't think that it's enough to just do the randomized clinical trial, no matter how well designed it is. And these 4 other trials that have been done were outstanding trials, and I was lucky to help participate in one of them. But you really need to establish that, or at least validate these findings in real world clinical scenarios with studies like CASPR.
I couldn't put it any better. That's outstanding. And I'm so glad to hear that there are some additional subgroup analyses coming. Obviously, we're going to have you back because there's a lot more to say on this topic. It feels like we're finally just starting to dig into this in the right way. Rather than closing the door on ESUS, we're finally opening it all the way so that we can really look inside and figure out what's going on. Thank you so much again, Jim, for being with us today. And again, check out the full paper titled Outcomes of Patients with Embolic Stroke of Undetermined Source Treated with Antiplatelet Agents or Anticoagulation, a Multi-Center Cohort Study.
Thank you, Dan.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.